it's the way we work out how much it costs the organisations we work for to deliver the healthcare services that they provide. Why do we cost? Many reasons. So basically, one of the primary ones is that's how we get our income. So income and cost are completely different, but we submit a full cost of our organisation. It's a mandatory financial requirement. There's only two mandatory financial requirements. One is the annual accounts, and the other one is the costing return. So we submit that to NHS EI, and NHS EI use that information to come up with tariffs that most organisations get paid by. That's how they get their income. You'll have seen, obviously, throughout the pandemic, things like how much we spend on COVID. That information that was collected was used then to lobby the Treasury for more money. And then the other reason why we cost is we're actually, well, we're spending taxpayers' money, so we have to use that money effectively and efficiently. And what we're able to do when we submit those costs is then benchmark against other organisations. And there's initiatives like GIRF to get it right first time, and model hospitals that use that information to improve the efficiency and effectiveness of the NHS. And obviously, there's lots of information out there on the big one at the moment is how much cost we're spending on like health inequalities and health promotion, and how can we reduce patients coming into hospitals by spending more actually in the social care sector or in primary care. So it's about where the cost is actually being spent as well, not just how much it costs. So in the past, there was something called reference costs. So reference costs were the average unit cost providing secondary care to NHS patients. They've been collected every year since 1997. They're collected at what's called a healthcare resource group level, HRG. So a HRG is basically it's like an algorithm. So we record diagnosis codes and procedure codes in the hospital that against every patient. And when we put those diagnosis and procedure codes into what is called a grouper, it will spit out a code that says this patient has had, I don't know, a knee operation and they've had major complications or minor complications or no complications. And those codes are actually how we get paid in the acute sector. And every trust will get the same level of income. So for a knee operation with minor complications, I don't know, it might be like £5,000, say, and every trust would get £5,000 regardless of what that costs. And that £5,000 is based on a national average. So we're able to look at the cost at HRG level of any trust that's doing similar operations to us in Nottingham, and then we're then sort of, that's how we do the benchmarking. Really, we can see where we sit in the pack, and that's what this index that is referred to on this bullet point is. There's an index against every HRG, which basically, if your index is 100, it means you're at the national average. If it's 110, it means your costs are 10% higher than the national average. And if it's at, say, 90, it means your costs are 10% lower than the national average. So we use the index to see where all of our different procedures within the hospital sit. And we're able to roll that up at specialty level as well. So we could say, right, for cardiology, the index is at Nottingham, it might be 110. So our service is 10% higher, or costs are 10% higher than the national average. What is driving that? I'll just ask everybody put their microphones on mute because there's a bit of feedback. Thank you. As I've said before, the costs we submit are used to provide the basis for the tariff. At the moment, I won't go into income, but at the moment, there's a lot of block funding within our income. So we're moving we've moved slightly away from tariff because of basically their environment we're in at the moment. Hospitals being in a pandemic, we need sort of we're not doing a lot of elective work, so we've moved to a lot of block, but there will be a shift back towards tariff or part block, part tariff in the future. And actually those block fundings that we get are still based on the cost that we submit to NHS. The whole reference cost collection has now been replaced by PLICS, which is patient level information costing systems, and the national cost collection. So that is basically similar to the reference cost, but a far more granular detail. So then our NHS now collects granular information at patient level, which means there's a portal that we can go in and look at, patient pathways, and eventually when they start collecting across all the sectors, we'll be able to look at patients as they move through primary care, mental health, acute hospitals, and look at the whole pathway. So the present PLICS and SLR, as I said, is patient level information and costing systems, and SLR is service line reporting. So patient level costs are calculated basically by tracing the resources used by a patient and getting the activity against the patient alongside the actual costs that the organisation incurs. As it says there, it allows more detailed analysis of costs versus income, so we can look at profitability of certain procedures that we do. And what we're able to do then is work with specialties around how we can look at waste reduction or quality improvements. We obviously link this as well to outcomes, so it's not just all about the cost. We can look at outcomes and go, always the best quality is usually cheapest in the long run. So we look at things like readmissions and time, length of stay and stuff like that, how long the patient's been in the hospital, when they were medically safe, for example. So patient level, it combines costs and activity. It highlights clinical variation because we're able to look at patients by consultant or by ward, do full pathway analysis. We can look at the coding and the counting, which is basically how many diagnosis and procedure codes are recording against every patient, and is there a difference again by consultant? So that's the clinical coding stuff. And we're able to look at profitability analysis. So do we get the right income for the costs that we're incurring? So service line reports and how this differs to traditional financial reporting. A lot of you might already be budget holders. So traditional reporting, basically this is a diagram of our services. So each clinical management group, and you've got the different sort of divisions within that, women in children's, for example. And then within SLR, you'll have the same divisions, but what happens is all of the indirect costs, so your support services and certainly all of your overhead costs, as you can see, corporate facilities on the right-hand side, they get absorbed into the areas that are actually providing patient care. So it shows what service line reports is showing is the full cost of what it costs to run those services, including overheads, including things like theatres, therapies, radiology, pharmacy. So all of the indirect costs or the support service costs actually get rolled into the patient-facing areas. Bottom line is still the same, and within our reports we've still got a bit holding in central and research. Some of the support areas do actually have patient-facing areas of their own. So the physiotherapy service, for example, will see outpatients. That's why there's still some costs and income, and it hasn't been fully absorbed. But all of the physiotherapy that happens for inpatients will actually be absorbed by the services that are consuming that. So that's basically what this page identifies, that there's two key differences between SLR and traditional financial reporting. SLR doesn't look at budgets, it's looking at actual costs. And SLR allocates the cost from the support and corporate areas to the clinical service lines to create a true income and expenditure variance. There's still a need for the traditional budget reporting. If you're a ward manager, for example, you still need to know what your staffing levels are. Budget reporting is very good for expenditure control and financial stability. So we still need to set budgets for people to work within, but the service line report actually it enables us to look at whether a service is profitable or not and sustainable, and how we actually then make it sustainable is where the patient level costing comes in. So how do we do patient level costing? We take lots of feeds from all over our trust. So we get our PAS system, we get consultant episodes, we'll get an outpatient system, we've got an ED system, and then we get things like all the smaller services, like maybe there'll be a renal dialysis feed. We get the general ledger costs. We take our income from our income system. We get feeds then from a lot of the drivers, so things like how many the ward stays and how many minutes every patient has been on a ward, the theatre minutes, the pathology tests, imaging exams, drug issues, therapy contacts, high cost devices and high cost drugs. These are all the feeds that get pulled into the database that we've got. And the output of that is we're able to show an itemized, what we call a patient bill. So we can show, patient came in, they were in for 4 days. We did this on day 1, it cost this. We did this on day 2, it cost that. How quickly when we're able to look at when we did certain things. So did we get them to theatre in day 0, or was it day 1, or was it day 4? And we're able to look at why we did certain stuff. So you get an itemized bill. You get the corresponding income, so you're able to look at the costs versus the tariff. It's supported by the activity data, so we can look at how many tests we did, for example. And it can be aggregated because it's at such a granular level, patient level. We can aggregate it at specialty level, divisional level, consultant level, day of the week, whether that has an impact on whether we do certain things, like weekends, for example. So we're able to look at it in many, many, many different ways. So what can it show? Here's some examples. So this is a summary report that basically it's showing at HRG level where our top loss-making HRGs are, top 5 profit-making HRGs within a certain specialty. We can look at cost by consultant, or length of stay by consultant, or income by consultant, and we've grayed out some of the consultant names there. This is within trauma and orthopedics, and we can look at things like we can drill in through patient type, so we can just look at all of our inpatients or all of our outpatients, and keep drilling down to a level that we want. And we can look at things by teams. If there's certain consultants that work in a green team or a blue team, and we know who they are, we can make groups up. So it's customizable to wherever, which service is using it, really. So what we're able to then do is look at things like average cost. This is a typical HRG code. It's a 5-digit code, which is HT12D, which means very major hip procedures for trauma with a complication and comorbidity score of 3 to 5. But we're able to look at what our average cost is by consultant. So we can see there's a variation in cost. We're able to look at what the average income is by consultant, and therefore what the average margin is. So we can see that some consultants lose quite a bit of money, and some consultants make a bit of money. And and this is all within the same HRG. So usually that means that the thing that's driving the cost, certainly for major hip procedures will be time in theatre or length of stay after theatre, or it could be length of stay before theatre if we've not got them to theatre in time, and that's the sort of thing that we start to look at and go deep into the data. And again, this is the drilling in. So average theatre costs by consultant, and again, that's driven by time usually. So we can see there's a big difference. And what we try and do with the service then is work out what is an optimum pathway for this type of procedure, and what's the optimum theatre time, and is there anything we can do to get those lines flatter rather than having these curves. Average length of stay, you can see most of the bubbles are similar, but there's one right up here that's got an average length of stay of somewhere around over 18 days, and that'll be a consultant. That again, it may well be that consultant, you'd say, well, does that consultancy have all the complex cases? But these cases are all fitting within the same HRG. So it is, and a HRG is based on the diagnosis and procedures of the patient. So you'd think, actually, it shouldn't, because the algorithm is saying these are all very similar patients. So this is the patient bill level. It's not showing the cost, but it shows what we're actually doing to a patient on each day of the week. So this is a 11-day length of stay patient, fracture neck of femur. And it shows that they went to theatre on day 2, which was a Wednesday. They were admitted on a Monday. So some of the work that we do with my team is looking at, well, why was there a 2-day delay to get that patient to theatre? The green blocks are the cost of the wards. So you can see they're on a ward every day. The red bit is the medical round. So they had a medical round every day. See, we had a radiology test on Monday the 7th. And basically we were discharged on a Friday. So what we're able to do then is look at, well, when we get patients that get discharged on, say, Mondays, could we have got them out before the weekend? What do we do at the weekend? You know, there's not a lot happening at the weekends here as far as, you know, I think there's a bit of blue, which is therapies. So there's some therapies going on. And that's the sort of thing that we look at. So they've had therapy pretty much every day, which is good, because what we often find is therapy doesn't happen at weekends, but for this patient it did. And we've done a bit of work within our geriatric medicine department that looked at patients that were having therapy Monday to Friday, no therapy Saturday and Sunday, and then starting again Monday to Friday. And with older people, that those 2 days not having therapy was taking them backwards, and it actually, we've put something in place now where therapy continues throughout a weekend. And having this data like this visually, working with consultants is great to get for service improvement. The challenges, so understanding the services. So we work at Nottingham, we do quite an intensive program with our services, but the first bit is understanding the services and understanding the data that we've got on the services. The availability of appropriate data, it's only as good as what information we collect, and we need clinician input, clinical engagement to make that data better. And that's, you know, we've got a data quality group at Nottingham that is clinician led, and we work, you know, we've had that for over 10 years now, and the data has improved massively over that period. Benefits of PLICS. So it understands the economic drivers. There's a transparency of income and costs. It's really good for benchmarking. So we benchmark ourselves against all of the major teaching hospitals outside of London. We can identify differences in practice or differences in pathways. We inform future grouping and classification of patients. So that's obviously providing the information back to NHSI, who will then improve the HRGs that they use. As I've said before, it informs tariff setting. We do deep dives on coding and counting. So we look at how good is our coding, you know, get notes out and compare the notes versus the data that we've got. And it's extensively used at Nottingham for business case development. If we know we're going to increase a service or, you know, new consultants coming in, we're able to look at if activity increases, where will that impact on? You'll need more therapies, you'll need more, you'll need CT, you'll need pathology tests, for example. So any new business case development now comes through our PLICS system. Does it really make a difference? I won't read these out. The slides are going to be circulated after this. So but there's like at least 7 or 8 trusts there that are showing that absolutely yes. You know, there's a lot of organisations now using PLICS to make a difference. We've got something like a £40 million cost improvement programme at Nottingham, and a huge part of that is done through our waste reduction and service improvement team using patient level information to get us to provide more effective, more efficient service and sustainable services. And that's not always just pulling cash out of the system. That's a lot of the time it's actually expanding the service, but without actually having to expand the costs as much as we're expanding the service. I've got some examples of some of the work that we've done at Nottingham using our PLICS system. And as you can see, there's no numbers. Well, there are some numbers because they're clinic codes, but there's no pounds on this at all. So this is the this is doing some work with our audiology department, and we the problem they posed is they got what they thought was a very simple pathway where a patient comes into this first. Each one of these blocks across is an attendance by a patient, and patients come into this assessment clinic, the U27DY on the far left, and then are supposed to go to a fitting clinic, and then or possibly a DWAX clinic, and then a fitting clinic, and then after that they're supposed to have an outpatient appointment once a year. And this data was showing over the last 5 years how many patients we had come in for an assessment and go for a fitting, and they couldn't believe how many patients came in for assessment and had no attendance after, or came in for an assessment and went to various other different clinics within the audiology service, which wasn't the pathway that they should have been on. And visually, this just shows a spider's web of how complex the service is. And what they've used this information for is to dig deeper and try and streamline their service. So what they thought, what they discovered during the 10 weeks we worked with them was they got patients on multiple pathways. They've got lots of lost patients. So that's patients who come in, have 1 appointment or 2 appointments, and then just disappear. What they found was the interaction with the ENT, our ear, nose and throat, was not efficient, certainly for the paediatric patients with glue ear. So there was a lot of patients, children being passed from audiology to ENT, back to audiology, back to ENT. So some of the solutions they've done, we're looking at putting audiologists in GPs, making it easier for patients to access the service. At Nottingham, it's not in the easiest of places to get to. It's right in the city centre, so there's hardly any parking. We're looking at online hearing tests, so having the technology so patients don't have to come in on site. Online ordering of spare parts, and patient-initiated follow-ups, because there's a lot of DNAs that we've noticed within the service. Another one, completely different dashboard. So we build bespoke dashboards with every service that we work with. So this was looking at outcomes for spinal surgery, and it was a huge loss-making service, spinal surgery. So losing about £7 million a year within this service. And we knew, or before we went in, the consultants knew that the degenerative part of the service would be the biggest loss maker. So we built a dashboard that basically grouped all those procedures and diagnosis codes into surgery types that the consultants wanted to look at. They told us how they work, and they said, right, degenerative, trauma and tumor, adult deformity, pediatric deformity. So we're able to push those diagnosis or procedures into one of those categories so they could look at a dashboard in a way that they wanted to look at it. And they've got filters down the right-hand side that enable them to click on whether the patients were adults or pediatrics, what type of intervention, the diagnostic intervention, injections, no intervention, or been in theatre. And there was a theory which we were able to bust, that all of the patients from out of area were the problem patients, if you like. But actually what we found was that, yes, the out of area issues, the out of area patients were causing losses, but the Nottingham patients were causing bigger losses. So it wasn't just the fact that we've got everybody else's patients that were like higher acuity, if you like. So the specialty knew it had an issue with the degen pathway from an operational and a risk perspective. The dashboard just helped triangulate it and the financials through the patient pathway. What we asked was, what quality initiatives can we put in place to solve this? When we drilled in, because we're able to click on any of these bars and drill in, when we drilled into the degenerative, we were looking at, what we're able to see is there's loads and loads of cancellations. And why were the cancellations? And what we found was the cancellations were to do with a scarce resource of critical care beds. And the other option we found was actually we could have some step down beds instead, because we didn't need a full critical care, but it needs some sort of ring fence beds. Same sort of thing with length of stay. It wasn't highlighted as an issue by the specialty, but we're able to benchmark length of stay, and within our degenerative area, we found that it was a big problem. And they came up with an initiative around the pain pathway. There was a lot of waiting for pain relief. So they had a start point, basically. They had some ideas when they came to us, but the dashboard sort of helped them enhance those ideas and actually put some figures on the ideas and come up with some solutions for the ideas. So discovered, say, degen was the biggest loss-making area. Although pediatric deformity was making money, there's lots of cancelled ops within it. Injections were being carried out in interventional radiology, and spines had actually got theatre utilisation to do it in their own theatres. And at the same time, interventional radiology needed more space. So it was a win-win. We were able to switch where we did the pain relief injections. And we noticed there was poor coding compared to neurology. So that was down to the clinicians not recording everything on the paper notes that needed to go to our clinical coders. So what we're able to do is, as you can see at the bottom, there's now a clinical champion for coding within the specialty to improve coding. We invested in nursing staff on a paediatric ward with high nursing acuity, so only the most severe patients go to critical care. That enabled us to get more patients through the service. Flexible theatres allowed us to extend or shorten the list. So what they were doing was having a 7-hour operation, but always booking a 9-hour list, because the lists were sold by our theatre team in blocks of 4.5-hour lists or 4-hour lists. So we're always planning to waste 2 hours of theatre, which just seemed crazy. So they've got now more flexible theatres. So they either have a very long list that they can do a big operation on and some shorter operations, or they have a shorter list and just do the shorter operations. ERAS and SDEC opportunities, that's same day emergency care and emergency recovery after surgery. So different initiatives to get to reduce length of stay. And the outcomes of that is we've increased our activity in certain areas, certainly the paediatric area from 120 scoliosis operations to 172 per annum. Our risk score, because a lot of children were waiting over a year, has gone from 20 to 0. Our cancellations have gone from 50% to 10%. The waiting list has gone from 150 to 50. Average waiting time has gone from 21 weeks to 10 weeks. And the length of stay has gone from 6.7 days to 5.1 days. And all of that, and we've focused on all of that, and the money drops out then. And what we've seen so far is that the margin has improved by over £2 million within spines. On our healthcare of elderly people, another example, they were looking at the patient journey. They wanted to look at frailty scores. So they wanted to bring some non-financial information into our PLICS system. The consultant said we record frailty scores for anybody over 65, and actually within our geriatric medicine patient, sorry, anybody over 74, what they were saying was we don't need everybody over 74 in our service. We need elderly frail people in the service, but anybody that's got a frailty score of lower than 6 probably should be somewhere else within the hospital. So what we did was a bit of just an experiment, and we looked at patients presenting with primary conditions that weren't just like elderly, falls or anything like that. It was, so we've got heart failure, and we were able to prove that patients that come in with heart conditions, certain heart conditions, are better off being in cardiology than in geriatric medicine. But 9 times out of 10, if they're over 74, they'll go to geriatric medicine. We're trying to get the patients in the right place first time. We looked at variation in outcomes by discharging specialty, primary condition, age, and the frailty score. And we looked at variation of different wards within the service. Again, a different dashboard, but basically what this dashboard is showing is for these 4 different HRGs, heart failure or shock, syncope or collapse, arrhythmia or conduction disorders, and unspecified chest pain, the average length of stay in HCOP is 11 days, and in cardiology it's 9 days. And this one is 6 days in the HCOP and 2 days in cardiology. The next one is 6 and 3, and the next one is 4 and 2. So pretty much half, we can halve the length of stay of patients being in the hospital if we get them in cardiology for certain conditions rather than pushing them into HCOP. And that's what it says at the bottom, really. They've got a lower length of stay. They've got some higher readmission rates for certain conditions if they go to HCOP. We're still doing further analysis. This is, fairly recent information, but we're looking at a possible solution is to create a cardiogeriatrician service or an HCOP in-reach service where they will go and support higher frailty patients with cardiac conditions rather than being pushed onto a HCOP ward. The PLICS, the wider context, those few slides were just some examples of what we're doing with PLICS, but I don't know whether a lot of you might have heard of Model Hospital, but there's within the Model Hospital, which is a national portal that you can all access, The model hospital basically is a big benchmarking tool. It shows there's £5 billion worth of unwarranted variation. There's a 5-year forward view that says there's a £30 billion funding gap. You've got initiatives like Get It Right First Time, GIRFT, which is closely linked to the model hospital and uses that information to look at how different services are effective and efficiently using NHS money. We've got the CTP, which is the costing program. So that's the National Cost Collection. I say that's now collecting more granular information that will feed the model hospital and feed GIRFT. And they've rolled out to mental health and community services. So we'll be able to get a fuller picture of and track patients through the system. And yeah, delivering care at its best. That's partly my job now that I work with our services to try and deliver the best care for Nottingham in a sustainable way. What's needed? We need to produce good quality costing, and it's got to be underpinned by NHSI's costing principles. So there's specific guidance around how we all cost. So we do the same thing, no matter which trust we're at. And that enables better benchmarking and a higher standard of costing. So it should be based on high quality data. It should include all of the costs. It's got to show the relationship between activities and the resources consumed. To get clinical engagement, we need transparent processes that allow detailed analysis. We tend to focus on the materiality, and we always do. We'll look at the biggest procedures that we do and look at the materiality of the costs within that. Got to be consistent across all services. So the way we allocate, I say there's certain standards for the way trusts should allocate theatres or therapies or radiology. And absolutely, we need clinical engagement and non-clinical stakeholders. So at my organisation, we've got a PLICS steering group that's got 3 clinicians and exec members and members of the costing team and service leads. So, it's in everybody's interest to get this information right. It's really important information that we use to run our business. And expand the use of costing data across your organisation. I provide regular board level reports. Our divisional teams have access. We've got 600 CLIC licenses, which means that clinicians and divisional teams can go in and look at these reports. We update our PLICS monthly. A lot of organisations do theirs quarterly. Business case support, transformational support, which is where most of my work is now. Support model hospital and GIRFT reviews when they come into the hospital. Align outcome data with other performance measures. That's in its early infancy, but that needs to be done more to look at actually which patients are getting the better outcomes and how is that linking to cost. And improve accessibility and the relevance of data. So final few slides, it's like it is obvious, but finance staff, we're not experts in patient care. We're finance people, so we can give good costing outputs, but we need clinicians to be involved in those outputs and tell us where things are wrong, where they could be better. I work with my clinicians at Nottingham a lot, and the data has improved no end. So now we've got a big clinical base using patient level costing regularly. We need to engage because at the end of the day, clinicians are the people that consume or use the resources, understand how the resources get used. A lot of the time they know what data is recorded on the shop floor. So when I go to service, quite often the clinician will tell me there's a local database that somebody keeps and we've got all the information on there, or we collect this information because it goes off to our our professional body, so we can get you that information. And clinicians usually have a hunch of what could be improved and where they see waste and what really annoys you about your service. So that's the sort of stuff that we get very early on when we go into a service. We'll ask those questions and then try and either bust that myth or back that information up with the data that we've got. Costing data can identify new areas of opportunity as well, like I say, through the internal benchmarking and wider benchmarking, and it pulls together a wide range of information. I think our costing data now has got more non-costing information in it, things like medically safe dates and frailty scores and all of the population health management around people's deprivation, and there's a deprivation index. Although now we're looking at ethnicity and how much we spend, what readmission rates and DNA rates are by ethnicity. That's not even costing, but it's all within our patient level information system now. If you want to know more, the slide deck I'm going to give out, there's an email address that is my team's email address, PLICS@NUH. By all means, contact us and we'll put you in touch. If you don't know who your costing colleagues are in your organisation, I think we probably know most of the costing colleagues around the country anyway. So by all means, contact us and we can put you in the right put in the right direction for people in your own organisation. And there's a few links there to future focus finance pages as well. I think that's it. Any questions? Got about 15 minutes. No questions from anyone?
Hi.
Hi. That's all right.
Comment, really.
Yeah.
We've had a series of savvy sessions, so value added sessions to try and improve quality of care and value added to our service. And just to say that, and we've also had microsystems going on for the past 2 years, and there is a limit to how much goodwill you can ask clinicians kind of to give.
Yeah.
I mean, we're happy to do it, but there comes to a point where, we're just getting asked more and more times to do extra things in our job plans that we're actually not paid for.
Yeah.
So we're all very happy to do this, but I think it has to be factored in that if we're going to give up our time, it has to be organised appropriately, and that you and I are both going to get the best out of that session.
Yeah, absolutely. Yeah, there's definitely got to be an incentive to get involved in this. A lot of the work that we're doing, like if we were working with a service, say we go in for 10 weeks, that usually has an exec sponsor attached to it, and there's usually and within that 10-week period, there is at the end of it a what we call a confirm and challenge session with the execs, where we go, right, this is what we found out about the service and this is what they need to be able to improve, whether that is they need ring-fenced beds, whether that is they need to have the cardio-geriatrician in HCOP. That all goes through as it's more like it's a bit like a Dragon's Den thing at the end, where we just go, right, this is what we've done, this is what the consultant's saying, this is what the data says. And if the execs are there going, actually, yeah, that's a no-brainer, just get on with it, which is what they did with spines. They just went, get the people in, get the extra resources you need for the nursing, ring-fence the beds, and just crack on with it. Because if it's going to reduce the risk and it's going to reduce the waiting list, then it's a bit of a no-brainer. And at the same time, we're improving the data in that area that we're working with. So we don't usually, I don't go to clinicians going, I need your time, but actually I just need it to make the data better. There's always an end point. Any other comments or questions from anybody? No, okay. Thanks everybody for attending and listening. And if you've got any questions afterwards,
Thank you.
by all means, that's all right. By all means, you know, the presentation, Megan, I'm sure you'll send out, won't you?
Yeah, I'm happy if you've got any questions, you can send them to me and I can pass them on to Scott. But thank you very much, Scott. That was really great.